Next up is Dr. Jitendra Jethani. Needs no introduction in pediatric ophthalmology world, and his topic is practice workflow optimization for myopia control clinics.
So, thank you so much. I would be speaking mainly about how to see the patient, what to do when the patient comes to us. When we see that this is a particular patient who is having myopia, we have to do some baseline investigations and then see whether he's progressing further or not. This I think will be taken care by other speakers, how to start or set up a myopia control clinic. But since I was talking about it, I thought that there should be some few points on that. And this is the workup which is taken from the AIOS guideline for myopia progression control management. This was, we came up with this, I think it has been like now 3-4 years. So these are some of the investigations which are in the must do, good to do. And I think that most of the investigations which are in good to do have been shifted into must do now. So I would be showing that also. So this is the first step. I was just talking about the similar things. First step is to take the history and first of all get the risk factor analysis as to this particular patient may have a progression. We are not starting the treatment strategies in these particular patients, but these are some of the patients who may progress into go for myopia progression. Younger age, if the patient has young and has started developing myopia, parental myopia, sibling myopia is there. There is a history of lack of outdoor time. There is excessive near-based work, and there is a history of fast progression. So these are some of the things, and then we come to the second part of it, that is the diagnosis. Diagnosis, we all are ophthalmologists. We are doing our work fine since years. We know how to do a cycloplegic refraction and prescribe glasses. The part 2 is that you have to do a baseline K, baseline axial length, do a good fundus evaluation for myopic patients, and corneal thickness if it is possible. So these baseline investigations are important because these would actually tell you whether myopia is progressing and how it is progressing, whether the axial length is actually changing or not changing. So who is progressing? This is very, very important, and how much progression is actually significant. So myopic progression is actually defined as a progression of glass power by more than 0.5 diopter over a year. In terms of axial length, in our clinic we define as a progression of 0.2 millimeter beyond 14 years, because past 14 years we do not really think that there would be a great progression. So even if there is a small progression of 0.2 millimeters, we take it as a significant progression. Under 14 years of age, 0.3 millimeter progression is what we take it as a significant progression. So otherwise there should not be any change in ocular biometrics. There is a small point of pre-myope. The pre-myopes are nothing but they are not really myopes, but they are like very small myopes or emetropes who may have a history or risk factors, sibling myopia, parental myopia, or there may be a history that they have been progressing axially. So there is a history that they have been having axial elongation, and that is mainly because they have other risk factors. So if there are risk factors and if you have evaluated these children as progressing, you can take them as pre-myopes. The key point in all this gamut is myopia progression. So these are our recommendations that which we follow at our clinic. Pre-myope who are non-progressor, you don't have to do anything. Even if there is a history of sibling myopia, parental myopia, you just have to wait and watch for the progression to occur. In the meantime, the most important intervention, most powerful intervention is behavioral changes, outdoor activities, less near work, less screen time. That is the most important intervention that we can do when there is no progression and we want to stop any other progression that can happen. Pre-myopes, if there is a progressor, if there is a history and you have a backup data that this particular patient was plus 0.5, has become emetrope and is already minus 0.5 or minus 0.75, and there is a serial increase in axial length, you can definitely think of some myopia management strategy. And if there is a myopia progressor, we would do certain investigations like accommodative lag, peripheral refraction, and then think of two major strategies, which are either low concentration atropine or peripheral myopia, peripheral hyperopic defocus glasses. Just a minute. Yeah, so this is more or less our strategy of first line treatment. The only reason I'm not here to discuss really about atropine. The lecture is more about what we do in our clinic, more of what we practice. So the most important thing is that we follow them up. After a month, once we prescribe them drops, we want to see whether there is any increase in pupil size or not. We check their accommodative lag. We look for any binocular abnormality. We do the cover test after giving 0.01%. There have been cases reported where patients have developed esophoria post 0.01% because it suspends the accommodation subnormally. Not really, it completely removes accommodation. At 3 months, we would again check the visual acuity, pupil size and compliance. We would check the compliance at 3 months because पहले महीने में तो everybody is really into it that myopia हो गया बच्चे को, we will do something about it. By the end of 3 months, everything sort of gradually goes down. So we have to do a compatibility check. We have to do a compliance check whether patient is actually putting the drops or not. And at the end of 6 months, we will do check whether there is any behavioral modification, reduced near work or not, outdoor activities, and repeat cycloplegic refraction, axial length, baseline keratometry. This is another intervention. My focus is more on the follow-up schedule and evaluation. So once we prescribe peripheral defocus lenses, be it Hall lenses by Stillest or Zeiss Care lenses or DIMS lenses, we call them back again after a month and we see whether they have any problems in the visual field, because the central 9mm is actually the clear zone and there is a peripheral defocus. There are plus 3.5 to plus 6 lenses depending on which particular glass we are choosing, and at 6 months we do all the battery of investigations. So this is the summary of the whole workup that we do at our myopia control clinic. The first part has the history and then there is evaluation. Then we categorize them whether they are a progressor or not. So the key, as I think I have been repeatedly saying, is that the key is whether there is any progression or not, and if there is a progression, then we think of what would be the appropriate strategy. But we have to see the axial length, K reading, accommodative lab and binocular vision status, cover test, just to see that we do not increase or start any other new anomaly. So that was all regarding the workup. This is mainly about pre-myopes. Who are pre-myopes? There is no set management, but these are certain recommendations that can be done. Not really part of this is. So I mean, you can, if you want to take pictures, you can take when to initiate anti-myopia therapy in myopes. These are some of the recommendations that we do. And most important is to note progression and then think of appropriate anti-myopia progression strategy. So that's regarding workflow optimization.